Hi, good afternoon. This afternoon, we will be discussing about cough in COVID-19, both acute and chronic. We know that cough is a key symptom of COVID-19 in the acute phase of this infection and one that also persists in the post-infective phase. Cough is not only the distressing to patients, but it also increases the risk of community transmission of the disease by respiratory droplets. Stigmatization of patients with cough can occur, leading to social isolation, particularly during the COVID pandemic. Therefore, identifying ways to control COVID-associated cough could help to prevent community transmission and also the disease spread, as well as removing the stigma of this symptom. Patients with chronic cough also often seek many antitussive therapies, but it's really unknown whether such approaches are really effective in treating the post-COVID-19 cough patients. Now, the acute cough, which is associated with COVID, is quite commonly seen as dry cough is one of the most common initial symptom of COVID-19. We are all aware, reported in about 60 to 70% of symptomatic patients of COVID. The co-presence of cough, anosmia, and ageusia indicates that neuroinflammatory mechanisms might be operative in COVID-19 pathogenesis. As the cough reflex is mediated by the vagus nerve, interactions between the virus and the airway vagus nerve with ensuing neuroinflammation, they represent the likely primary events for the initiation of cough. Cough in the post-COVID syndrome is also very important because the symptoms of post-COVID syndrome include cough, fatigue, dyspnea, pain, and so-called brain fog, that is otherwise called as cognitive impairment, including confusion and memory loss. And these are associated with the deleterious effect on the activities of day-to-day living. Cough can persist for weeks and months after SARS-CoV-2 infection in some patients with differing severity of acute symptoms. So then what is the prevalence of cough in COVID-19? Cough was reported in various series to vary from 20 to 30%. So what I mean is the cough was reported in 20 to 30% of still symptomatic patients about 2 to 3 months after the onset of symptoms of COVID-19. So then what are the causes of this post-COVID cough? It is not known exactly why the post-COVID cough syndrome develops in some individuals, but there is some emerging evidence that female sex, presence of respiratory comorbidities, and the severity of acute COVID-19 presentation might be predictive of post-COVID-19 syndrome. Unlike cough that persists after the common cold or flu, the chronic cough in post-COVID syndrome is usually accompanied by other multi-system manifestations which might indicate either a multifactorial pathogenesis or some shared mechanisms underlying these symptoms. The concomitant presence of fatigue, dyspnea, pain, and cough could point to a derangement of the central nervous system. In the clinical management of post-COVID chronic cough, it is therefore important to exclude any pathological or structural causes such as fibrotic damage to the lung parenchyma or damage to the airways, which are caused by either the SARS-CoV-2 itself or due to the treatment provided during the critical care. These lung parenchymal changes are commonly found on the CT scans of adult patients with COVID-19, and these fibrotic changes can occur in almost 10 to 20% of patients with COVID. The lung fibrosis induced by COVID could increase the cough reflex sensitivity in response to mechanical stimulation of the chest wall, as reported in patients with idiopathic pulmonary fibrosis. Coming to the neuronal mechanisms of cough, it is found that in chronic cough, the concept of cough hypersensitivity has been developed with the notion that the cough pathways have been sensitized by amplification of the afferent signals to the brain stem. So neuronal mechanisms of hypersensitivity are therefore central to the cough of COVID-19. It is possible that SARS-CoV-2 infects the sensory nerves which are mediating the cough, leading to neuroinflammation and neuroimmune interactions as possible mechanisms of cough hypersensitivity. So how do you manage this COVID-19 associated cough? Although many drugs are on the market or is still in the development for the relief of this cough in COVID-19, but there's really no good evidence for their benefits in the treatment of cough associated with COVID. Sometimes only taking honey or opioid derivatives, which are opioid-derived antitussives, are recommended for cough. We know that opiates such as codeine or low-dose morphine could exert antitussive effects by acting on the cough reflex network in the brain stem and might have some effects in suppressing cough, particularly in the early stages. However, we know that opiates are not universally effective and they have associated risks of dependence, of abuse, or central side effects. Then oral corticosteroids were tried, but they were found to be no better than placebo in reducing the cough duration in non-asthmatic adults. So persistent cough in post-COVID syndrome might be driven by neuroinflammation, leading to a state of laryngeal and cough hypersensitivity, which is the basis for chronic refractory or unexplained cough. Therefore, gabapentin and pregabalin, which are neuromodulators, have been shown to be effective in controlling chronic refractory cough. Certain anti-muscarinic drugs such as tiotropium could be used to control COVID-19 cough because they can decrease cough sensitivity in acute viral upper respiratory tract infections. The charged sodium channel blocker NTX1175, which silences the nociceptor neurons, is a newcomer in the neuromodulator group that is being tried for chronic cough in COVID-19, but this could be also considered for acute as well as chronic COVID-19 cough. So summarizing, we know that cough is one of the most common presenting symptoms of COVID-19, along with fever and loss of taste and smell. Cough can persist for weeks or for months after the SARS-CoV infection, often accompanied by chronic fatigue, cognitive impairment, dyspnea, or pain, a collection of long-term effects referred to as the post-COVID syndrome or otherwise called as long COVID. The pathways of neurotropism, neuroinflammation, and neuroimmunomodulation through the vagal sensory nerves, which are implicated in SARS-CoV-2 infection, lead to a cough hypersensitivity. Neuromodulators such as gabapentin or opioids might be considered for acute and chronic COVID-19 cough. Thank you so much for patient hearing.